I would like to present my study, Ultrasonographic Assessment of Patients with Plantar Fasciitis and its Clinical Correlation, a pilot study. Plantar fasciitis is most common cause of heel pain in adults, with a lifetime incidence of about 10%. Biomechanical dysfunction of foot is the most common cause of plantar fasciitis, and its well-known risk factors are obesity and increasing age. Plantar fasciitis is mostly diagnosed clinically, although an objective, reliable diagnostic test may be needed. For that, ultrasonography serves as a non-invasive, cost-effective imaging modality to support clinical diagnosis. Assessment of demographic profile and USG findings in patients with plantar fasciitis and its clinical correlation helps to initiate proper treatment and monitor the prognosis of disease. So, aim and objective of my study was to evaluate plantar fascia thickness using ultrasonography in patients with plantar fasciitis and correlate with clinical and demographic features. I have conducted a cross-sectional study, pilot type, in my parent department, Department of PMR at Government Medical College, Calicut, in a time span of 2 months among 30 patients. I have included consenting subjects with unilateral plantar fasciitis diagnosed clinically and excluded study subjects with a recent intervention for plantar fasciitis and those who have history of other heel pathology or trauma. Patients attending PMR OPD with unilateral plantar fasciitis diagnosed clinically and satisfying inclusion and exclusion criteria were enrolled into study. After taking informed consent, interview was conducted to collect demographic and clinical features. Clinical severity of pain was assessed using visual analog scale on a scale of 0 to 10. Ultrasonography was done by a physiatrist who is blinded to radiological data. B-mode ultrasound was performed in prone position with the feet hanging over the edge of examination table. Coming to the resultant analysis, the study included total of 30 patients. Among them, 18 were females and 12 were males. The average age of patients were 49.25 plus or minus 4.12 years, and height was 159.25 plus or minus 11.276. Average weight was 67.35 plus or minus 13.78 kg, and mean BMI was 26.23 plus or minus 2.59. The VAS score was 6 plus or minus 1.29, and the mean duration of symptoms showed 6.35 plus or minus 2.90 months. And the plantar fascia thickness in the affected foot was 6.505 plus or minus 0.77, and in the normal foot it was 4.18 plus or minus 0.64. On assessing the correlation of demographic or clinical features with the ultrasonographic plantar fascia thickness in the affected and non-affected foot, I have got a weak positive correlation for age and plantar fascia thickness, and there was a strong positive correlation for BMI and VAS score with plantar fascia thickness. Among them, BMI showed a statistically significant correlation, while duration of symptoms showed a weak negative correlation with the plantar fascia thickness. A cross-sectional study was conducted at Nagpur by Suhas Aradhya et al., aimed to assess plantar fascia thickness and clinical correlation among Indian patients. They have studied 30 patients with a mean age of 39.8 plus or minus 8.8 years, and average plantar fascia thickness was 5.07 plus or minus 0.9 millimeters. And they found negative correlation between BMI and plantar fascia thickness. It was statistically not significant and contradicting to results of my study. In a study by Kathivada P. et al., average plantar fascia thickness was 4.63 plus or minus 0.55 mm. And they found statistically significant positive correlation between BMI and plantar fascia thickness, which supports my study. The limitation of my study were sample size was small and healthy controls were not included in the study. And study had observational nature and the study period was limited. So concluding, The present study showed increased plantar fascia thickness in affected foot compared to unaffected foot. Age and visual analog scale score showed positive correlation with the plantar fascia thickness. However, it was not statistically significant. Body mass index showed positive correlation with the plantar fascia thickness and it was statistically significant. The p-value was less than 0.001. Duration of symptoms showed negative correlation with thickness of plantar fascia. Ultrasonographic assessment of plantar fascia thickness can be used to support clinical diagnosis and monitor the prognosis of disease with treatment. Thank you.
Good presentation. But as you mentioned as a limitation, it would have been better to compare with age-matched individuals. Okay.
There were studies like that, plantar fascia thickness showing increased. There were studies showing there is difference in plantar fascia thickness with respect to age. So in future, I would like to further elaborate the study to calculate the age-weight difference of plantar fascia thickness in population and also to correlate with other risk factors.
Any questions from the audience, please?
So in your study, a lot of confounders will work.
Yes.
One, at what time you have measured the plantar thickness? What time of the day? Because the photoplethysmography studies have shown that the feet will swell towards evening.
Nice.
So the thickness you are measuring in the morning will be different if you are measuring in the evening. That is one thing. Second, have you considered the possibility of pachyderma periostosis in these patients? Because you said that BMI, high BMI got a higher predilection. So naturally, they are having features of metabolic syndrome. So you have to include HbA1c as a correlate, as a confounder in this, because that is also acting as a contributor to increasing the plantar fascia thickness. Then what was the ultimate conclusion? People with the BMI, high BMI got a higher chance.
Higher chance of plantar fascia.
So can you use the plantar fascia thickness measurement using ultrasound as a screening to detect plantar fasciitis much earlier?
Yes, sir. In patients with a higher BMI, that has to be studied further. But based on this, in patients with a higher BMI, they have increased plantar fascia thickness in the unaffected foot also. So there is chance of developing plantar fasciitis in future, so that we can advise the patient about the occurrence.
So most of the time, plantar fasciitis is a clinical diagnosis.
Yes.
And do you think ultrasound is an additional tool necessary to confirm the diagnosis?
Most of the time, the plantar fasciitis is misdiagnosed in periphery also. So if there is a reliable, objective and dynamic tool like ultrasonography, we can avoid that misdiagnosis.
Okay.
So you think the thickness of the plantar fascia is directly causing the symptoms of plantar fasciitis to some extent?
Yes.
In that case, how do these people recover spontaneously? In most of the patients with plantar fasciitis, they spontaneously recover after a few months. Sometimes it may extend more, but most of them recover spontaneously. So do you think that the plantar fascia will become thinner?
No, sir.
Then how does it happen?
The inflammation will reduce.
So that means the inflammation is the component, not the thickness of the fascia.
The inflammation is causing the increased plantar fascia thickness. So we can use the thickness to diagnose
So you think that it is a temporary process. So then what is the role of screening?
We can have.
These are the issues.
Yes.
Hi, nice presentation. I have just a simple question. So most of your patients were middle-aged females.
Yes.
And have you considered barefoot walking in this? Are they normally barefoot walkers or they are using chappals?
They are mainly homemakers.
So probably barefoot
barefoot
walkers.
walkers.
Is there any relationship with the plantar fascia thickness and barefoot walking?
That has to be studied further, sir.
You have not considered that in your
not
study.
included in study.
Thank you.
Thank you. We'll stop with that. I just want to congratulate all the speakers who have kept to time, and they have taken the effort to do some studies and come here and face an audience and face some difficult questions. Thank you very much.
So we have come to the end of free paper presentations for today. To honor our esteemed chairpersons, I now invite Dr. N. George Joseph to kindly come forward and present a memento as a token of our appreciation.